Good afternoon. Welcome everyone who is connected now to this meeting. The topic is about genetic diabetes, and we'll have a focus on Wolfram syndrome. And this is a joint webinar from the European Society of Endocrinology, European Society of Paediatric Endocrinology, and Endo-ERN. I welcome also Tim Barrett from UK, Federica Delia from Italy, and just a brief technical notes during these meetings that will end at 6 p.m. There will be the possibility to ask questions through the question answer button on your screen, and there will be 5 minutes for this point. The meeting will be recorded and will be available through a website, throughout the website shortly after the meeting. So, welcome again for everyone who is connecting now, and I will give you a brief introduction about the first speaker, which is also a friend, Tim Barrett from UK. Tim Barrett actually is a Leonard Person Professor of Pediatric and Child Health in the Department of Cancer and Genomic Sciences in Birmingham. And he's an honorary consultant in Pediatric Endocrinology and Diabetes and managing director for the Wolfram Clinical Research Facility in Birmingham Women's and Children's Hospital, UK. He's a director of the Center of Rare Disease Studies in Birmingham and research director for the Central and South Genome Medicine Service Alliance and the co-leads of the Genomic England Clinical Interpretation Partnership. He led the National Health Service for National Specialists and the Commissioner Services for the Rare Diabetes Syndrome, Wolfram, Alström, and Bardet-Biedl, and run a busy clinical practice of general diabetes, type 2 diabetes in children, and as a tertiary endocrinology center. He's also an enthusiastic teacher and communicator, and on the themes of genomics and rare disease, and the lectures widely at the national and international level. And Timothy contributes to the local and national media and advises the BBC on stories relating to childhood obesity and metabolism. They publish over 200 research papers in scientific journals, and they receive major grants from everywhere, I think, Medical Research Council in Europe. So he's a well-known and worldwide known expert in the field of Wolfram syndrome. So thank you, Tim, for joining us today and for your time you spent, and the podium is yours, and thank you again.
Thank you so much, Pietro, for inviting me and colleagues. I'm very grateful for the opportunity to talk to you about genetic diabetes today, and with a particular focus on Wolfram syndrome. So thank you so much. What I will do over the next 40 minutes is I'm going to talk about a bit about the range of disorders. I'm going to give a couple of examples of monogenic and syndromic diseases, and then I'm going to focus on Wolfram with a clinical case history, the multidisciplinary management that we do, some key complications to be aware of, and an update about research. And I'll finish with some references for management guidelines for some forms of genetic diabetes. So first of all, when we think of diabetes and genetic causes, some of these will produce diabetes only, some with diabetes and features outside the pancreas, and some where diabetes is only occasionally seen as a complication of another syndrome. So diabetes only, monogenic, we can think about glucokinase and HNF1 alpha and some forms of neonatal. With features outside the pancreas, Wolfram is a clear example, and some other types like mitochondrial diabetes and some rarer ones like Alström syndrome. And then diabetes is an occasional complication in other conditions such as Bardet-Biedl and Prader-Willi. And I'll give a brief example of each of these as we go. The National Paediatric Diabetes Audit in England and Wales from 4 years ago showed out of about 28,000 children and young people with diabetes, as you can see, the majority, as you would expect, would have type 1 diabetes, 94%. But I wanted to show, although about 860 had type 2, the biggest monogenic, of course, is cystic fibrosis related diabetes. And then after that, monogenic, such as syndromic that we'll talk today, about 0.5%. So something like 1 in 200 children in a diabetes clinic could be expected to have a monogenic or a syndromic form of diabetes. We have. Thinking about syndromic, this is where there'd be a recognizable pattern of features outside the pancreas. And this is the commonest, as I've said, is cystic fibrosis. But the second commonest is Wolfram, hence the reason for being the subject of today's presentation in terms of having diabetes. So probably 1 in 150 children in a diabetes clinic would probably have Wolfram syndrome. And then others, such as Alström, Walcott-Rollison, are a lot rarer. The problem with syndromic diabetes is that they may present to other specialists. So they may present with diabetes, or they may present with sensory deficits, such as vision loss, cardiomyopathy in the case of Alström, deafness, or indeed obesity. And this makes it difficult to recognize patterns because they won't present to a diabetologist, first of all, and difficult to treat effectively. And how does this affect patients and families? Well, a delay in diagnosis has been a real problem for families trying to get a clinician who understands. And this is slowly improving with gene testing panels and genomic testing at birth. It results in multiple hospital appointments when families might have to travel to one hospital for a diabetes and another hospital for an eye appointment or another hospital for a heart appointment. Missed time off school, delays in clinic letters, and doctors not easy to communicate with each other and the different hospital teams. You can miss complications, and then there's missed opportunities to take part in research. And finally, there's a big issue about people being lost between children's services and adult services and keeping that transition going. So with that introduction, I'm going to talk briefly about what we used to call MODY, or maturity onset diabetes of the youth, that we now call monogenic diabetes. It's single gene disorder, but there are many different genes that can cause this. It does present in pediatrics, particularly in the teenage years, and often may be asymptomatic or just picked up coincidentally when a young person might be going in to hospital for another reason. Diagnosis is still made if there's diabetes, usually starting under 25 years, and ideally in more than one family member, following in an autosomal dominant fashion. These people can usually be managed with insulin less than half a unit per kilogram per day after the honeymoon, so at least 3 years after diagnosis. And as I said, you'd expect, not always, but usually, diabetes in an autosomal dominant fashion. It is a single gene defect, but there are now probably at least 14 subtypes recognized from different genes that will cause this. And they vary in how severe the diabetes is and what's the risk of complications if dependent on the subtype. And there's very good genetic testing available throughout Europe and indeed in the laboratories based in Exeter for the UK. I'm going to mention just the commonest one of these that would be seen in a European population, and these would be mutations in the transcription factor HNF1 alpha. And I mention it because it probably accounts for 2/3 of all monogenic MODY. It can present in young people and teenagers often. It's not always insulin dependent, but these young people don't tend to make ketones, and they have good glucose control despite a low dose of insulin, at least initially, and they still retain some insulin secretion, as you can measure with the C-peptide. They've often got a family history of diabetes, of people diagnosed older, 20s, 30s, or 40s, and glucose in the urine, despite relatively normal glucose concentrations, so often a lower renal threshold. Thankfully, they're very sensitive to treatment with sulfonylureas, but that has got the complication of being so sensitive that there's a risk of hypoglycemic episodes. And you can see if you do a glucose tolerance test that the 2-hour glucose rises very high and the 90-minute glucose rises very high, so a large glucose increment. And you can see this on this paper by Andrew Haddersley, Amanda Stride, and others, looking at a glucose tolerance test for patients with HNF1 alpha mutations compared to the slightly less common glucokinase mutations. And as you can see, the fasting glucose is almost normal with a fasting glucose of about 6 millimoles. But when it comes to 90 minutes, that incremental rise in glucose goes much, much higher than it would in other forms of monogenic diabetes or MODY, up into 12 or 13. And that's characteristic of this particular form of diabetes. So that's the commonest form of monogenic. And I mention it because it doesn't usually have extra pancreatic features if it's HNF1 alpha, although other forms do. So then thinking about conditions where there are extra pancreatic features, one of the commoner ones of this would be Bardet-Biedl syndrome. It's a recessive condition affecting about 1 in 100,000 patients. And again, there's over 20 genes in which mutations can occur and present with Bardet-Biedl. Only about a third will have the classic pictures of extra fingers or toes, and about 1 in 5 will have cystic kidneys, often picked up antenatally. They tend to develop obesity during infancy and may have mild to moderate learning difficulties, but not all do. Insulin-resistant diabetes is the classic pattern, and it will present in about 1 in 5 of these patients from the teens onwards, are probably related to the obesity. And of course, there's also sensory deficits such as vision loss in dim light. It's a ciliopathy disorder, so it's fundamental biology affecting the primary cilium and the transport of receptors up and down through that. And as I said, insulin-resistant diabetes is the pattern in about 10% or 10 to 20%. To make a diagnosis, you have to have primary features, often of renal abnormalities, which are classic, nephrogenic diabetes insipidus, and diabetes mellitus, as I've said. So those are the relevant ones that we would see as endocrinologists. And we've got a clinical service in Birmingham and London where we've got about 200 children and young people on the books with Bardet-Biedl, of which something like about 30 or 40 have insulin-resistant diabetes. The next one I'm going to briefly mention, and interest much more of my colleague Pietro's, who's the real expert, is Alström. It's another syndromic form of diabetes where diabetes tends to occur at puberty in an insulin-resistant pattern. It's autosomal recessive, and as far as we know, there's only one gene responsible, the ALMS1 gene. It's another ciliopathy disorder, and children tend to present in infancy with photophobia, so light hurting the eyes, cardiomyopathy in about a third, and then insulin resistance developing with the obesity, which is infancy onset, leading to extreme hyperinsulinemia, even more extreme than in Bardet-Biedl syndrome. And these patients often present with glucose intolerance, as I said, in their teens or early 20s at that point. There are other endocrine abnormalities such as hypogonadism and others. But the relevance to this compared to the previous picture is you'll see these two brothers with Alström syndrome. The light hurts the eyes, so they're wearing very dark glasses and they have visual impairment. And if you recall back on the picture of the child with Bardet-Biedl syndrome, does not have tinted glasses because it has low vision in dim light, but does not have the photophobia. So it's a sort of an easy clinical feature to distinguish between the two patients. So then coming on to the focus of this talk, and I want to spend the rest of this with, is Wolfram. And this, in contrast to the others, insulin resistant, this is an insulopenia. So there's reduced insulin secretion in this. It's an autosomal dominant condition. It used to be called DIDMODE as an acronym for diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. And the example I'm showing here is a brother and a sister who I met 30 years ago, who presented in early childhood at 6 with a classic history of weight loss, polyuria, polydipsia, and tiredness. And in those days, before genetic testing, they were assumed to have type 1 diabetes. But they were different. After 5 years or so, they started losing their color vision, and indeed most of their vision, and they were diagnosed with optic atrophy. And from the top right picture to the bottom right picture, you can see them on holiday in Cornwall by the sea, and you can see their white sticks because now they have vision impairment, and we don't see that in type 1 diabetes. As adults, they went on to develop other complications, including neurogenic bladder, ataxia, and a neurodegeneration. And the bottom left picture, you can see them as adults doing very well. The daughter there has got a mortarboard. She qualified with a first-class degree from Sheffield University in mathematics, so did really well. Sadly, the gentleman has now passed away, but the daughter is still well. There are 2 genes, but the vast majority of patients in the UK and in Europe have mutations in the Wolfram syndrome 1 gene. We used to call it Wolfram syndrome, but the name is really changing to spectrum disorder because we now know that there's a wide range of different symptoms that people see. The classic form, DID mode, patients will progress over time with a neurodegenerative disorder. And on the graph on the right, you can see that diabetes mellitus occurs in most people before 10 years of age, 50%, and most people will have it diagnosed by 20. Optic atrophy, or OA, develops again in early childhood, and most people will have it by 20. Diabetes insipidus will occur in about 2/3 of participants in the teens, and sensorineural deafness, again in about a half by the teens. Neurogenic bladder is more common than we thought it was and presents in probably about a half by about 20 years of age. And neurological complications, if you look hard for them, you can find them in the teenage years with signs of difficulty in balance and sometimes brainstem abnormalities. It's about 1 in 500,000 patients, but almost all, 85%, will have insulin-dependent diabetes, and so we will see them in our diabetes clinics. The diagnostic criteria for classic Wolfram would be the development of insulin-dependent diabetes mellitus and optic atrophy under 16 years. And if that's seen in the clinic, it's highly likely to be a diagnosis of classic Wolfram syndrome. But we've changed the name to spectrum disorder because we now recognize that there are adult onset presentations. And there are people who, healthy childhood, early years, but they develop slow onset optic atrophy and diabetes mellitus in adulthood. So there's a real spectrum of symptoms seen in this, and it's an unfolded protein response disorder. So the Wolfram gene encodes a protein that sits on the endoplasmic reticulum of all cells, particularly neurons and pancreatic producing insulin beta cells. And you can see on the left-hand side, Wolfram syndrome acts as a negative regulator to the unfolded protein response pathway. So normally, if a pancreatic beta cell is charged with making lots of insulin in response to glucose, the job of the endoplasmic reticulum in the pancreatic beta cell is to package that preproinsulin into insulin and the usual peptide chains. If the demands on the pancreatic beta cell are too great, it sends stress signals to the endoplasmic reticulum, which initiate a downstream cascade through ATF6 alpha, IRE1, and PERK to slow down the folding of proteins, to clear misfolded proteins, and to slow down transcription of preproinsulin further on. If that downstream cascade goes into, and that allows us sort of an adaptive and survival process to do. The Wolfram protein is there as a negative regulator to temper and slow down that unfolded protein response in response to ER stress. On the right-hand side, you can see in the absence of WFS1 or misfolded, it doesn't have a negative regulatory effect. So if there are endoplasmic reticulum stress to too great demands to make insulin, it's unresolvable, the downstream unfolded protein response cascade is initiated, but it is unregulated, and consequently, it switches on apoptotic genes and it shuts the cell down with cell death. And we think the same process is happening in neuronal cells and is responsible for the neurodegeneration as well. What's interesting now is that over the last 30 years since the gene was identified, we've been able to look at genotype-phenotype correlations. And in a very nice paper from my colleagues in Exeter, Andrew Hattersley and others, can show that the common type that I described is autosomal recessive, where you see diabetes mellitus, insipidus, optic atrophy, and deafness. But there are also milder autosomal dominant forms on the left-hand side, where you might see just late onset diabetes, or just early onset hearing loss, or optic atrophy and hearing loss without the full neurodegenerative picture. And on the right, there are also severe autosomal dominant forms that can present with neonatal diabetes or profound sensory neural hearing loss as a syndrome. So this is why we call Wolfram syndrome WFS1 spectrum disorder, because of a real variation in clinical severity between these conditions. Now, for the remainder of this talk, I'm going to talk about the middle form, which is the commonest that we see of autosomal recessive or perhaps classic Wolfram syndrome. And I'm going to give an example here. So the scenario I'm going to go through is a child that I saw in my clinic, born in 2006, and I saw this child when they were a bit younger. This is a girl called Tasia. I've changed her name. She presented with a classic history, age 7, of thirst, polyuria, and nocturia, and was diagnosed with diabetes. On general questioning, she'd had long-standing nocturia with some accidents and also in school as well. She'd been born after a healthy pregnancy and a normal birth weight. Her parents were first cousins, which fits with an autosomal recessive, of course, and was diagnosed initially as type 1 diabetes and started on insulin, multiple daily injections. At 8 years of age, after a routine eye appointment, she was found to have optic atrophy and was referred to the genetics service. And in common with many children now, blood was sent on an optic atrophy gene panel, and this identified she had a homozygous gene change, a missense mutation, arginine to leucine, in the Wolfram gene. So I saw her we have a national multidisciplinary service for Wolfram. When I saw her, she was 11, 40 kilograms. She had an A1C over 56 millimoles or 8.1%, and she was managed on multiple daily injections with insulin Lantus and Nevirapid. She had dilated pupils and urinary frequency, and when we cultured her urine, she had a urinary tract infection. So the optic atrophy, colleagues will know this and understand, and just for illustrative purposes, this is a fundoscopy photograph of optic atrophy in Wolfram, and you can see the very pale optic disc compared to the healthy creamy disc you should see in a person without Wolfram. The differential diagnosis here is autosomal dominant optic atrophy, which is seen in some families, but usually without the diabetes. And obviously in this case, we knew it was Wolfram syndrome, you can see. We considered what to do about her diabetes and how we would manage her diabetes, given that she was on insulin. And the options we considered was, should we add in metformin, optimize her insulin management, switch to a GLP-1 receptor agonist or an SGLT2 inhibitor? We didn't add metformin because this isn't an insulin-resistant form of diabetes, it's an insulin-deficient form of diabetes, and we didn't think metformin would help. We considered a GLP-1 receptor agonist, and indeed there is, I will mention it, there is some tentative evidence for the benefit of this in Wolfram, but given that she was her weight is 40 kilos and her total daily dose is 43 units, and she's still got a high A1C, we felt we needed to optimize her insulin management. So we put her on an insulin pump with a hybrid closed loop to support her. We didn't use an SGLT2 inhibitor because she had a urinary tract infection and we were worried about her bladder function, complications through that. So we optimized her insulin management. Other things that we were concerned about was her vision. With the progressive blindness, she had quite severe vision impaired. She was able to read a glucose meter and could see a drop of blood on the glucose strip, but she was going to need help. So therefore, we felt that putting her onto a hybrid closed loop with continuous glucose monitor was going to help her in the long term with her vision impairment. We investigated her for diabetes insipidus by trying to get a fasting early morning urine before breakfast for osmolarity and paired with a plasma osmolarity. And she had some evidence of partial diabetes insipidus, which we expected. So we put her on a low dose of desmopressin, but we would obviously have to be aware of overdose, which is a risk in these patients. She did have sensory neural deafness, which classically is a high tone pattern, and she benefited from hearing aids to support her. And then the thing we were most concerned about was a neuropathic or neurogenic bladder, which is part of the condition where some, not all, but some patients will lose bladder function and have difficulty in contracting. So the long-term management issues that we see in males is hypogonadism, the bladder instability that I mentioned. Not all, but some participants can have some bowel incontinence, again, due to autonomic nervous system dysfunction. There may be a loss of balance, and in some participants, there can be anxiety or mood disorder. So we put together a multidisciplinary team funded on the National Health Service, where we have an endocrinology input, genetics for family counseling, neurology, imaging, psychology, urodynamics, urology, and then family and social support as well. And the pattern we've been able to get support for Wolfram and indeed Alstrom and Barrett Beadle is a multidisciplinary clinic that meets 6 times a year with what we call a one-stop shop. So patients come from all over the UK to Birmingham once a year, and on the one visit, they stay for 2 days and they see myself as the endocrine consultant, my neurology colleagues, the clinical psychologist, the genetics counselor, urology and urodynamics, the eye doctor, and most importantly, family liaison support from Wolfram Syndrome UK, who really works between the families and the patient support group to support them in the clinic. And then also a nurse specialist and research nurse to take part in research studies. And we've used this model now for a number of different rare forms of diabetes, including Alstrom and Barrett Beadle. At the end of the clinic, we have a multidisciplinary team meeting, and we put together a clinical letter to go to the local team to make some management suggestions to look after them over the next 12 months. And since COVID, we've been able to hold some of these online and invite the local team to join us for the multidisciplinary team meeting by telemedicine. And that's been really nice as well. Been good. So I want to touch on some complications, first of all, next really about this. And because this is something that's been an issue for us in the last 3 years. So when we looked at Tass's results, we found that her creatinine was increasing and her urea was still normal. And when we undertook a urodynamics investigation, we found that she couldn't completely empty her bladder, and she still got half a litre of urine left in her bladder after completely emptying. And in double voiding, she still had some residual urine. And she developed a large flaccid bladder with obstruction and megacystis. And hence, because of the bladder stasis, she developed the E. coli UTI. So this really was causing chronic kidney disease, given the creatinine was rising. So we had to undertake an urgent catheterization to empty her bladder and support it. I'm pleased to say since then that the renal function has improved, but she's required a continuous indwelling catheter. So this is a pattern of a urodynamic flow of bladder emptying with an ultrasound, just looking at it. And you can see there's a nice bell-shaped curve as urine exits the bladder very nicely, but there is a delay of about a minute before it starts. But otherwise that's okay. And that's sort of an early stages of what we see in Wolfram syndrome, some patients. It then progresses to what we call a staccato urinary flow, where it stops and starts over time, and it doesn't completely empty nicely like that bell-shaped curve. And that's the sort of the intermittent stage when the bladder is becoming flaccid and poorly contracting. The final stage, which Tassio had, is this very flaccid, poorly contracting. And you can see the bladder flow, there's very little urine coming out on its own here at that stage. and that's why she needed catheterization. So an important complication for Wolfram to consider is renal function and bladder function, and avoiding obstructive uropathy. There are other complications which is important to mention, and this includes, as patients get older, again, not all patients, but some with the classical form, is swallowing or choking difficulties. And this is due to brain stem atrophy. It can be people who can choke on some foods. It can occasionally be liquids as well. And of course, there's a risk for the airway of aspiration pneumonia. I think it's really important to say it's not all Wolfram patients, but it's something to ask about and to step in and treat. And if we do have patients with these complications, we get speech and language therapy assessment and a swallowing assessment, and making sure that the airway is safe. And it's demonstrated on these MRI scans. So this is as you see, a coronal section through an MRI of a healthy young person and a person with classical Wolfram. And on the healthy young person, you can see the brain stem here, the pons, the cerebellum, and you can see the posterior bright spot, the pituitary here. And on the right, you can see the absence of the posterior bright spot, and you can see brain stem atrophy here, increasing fluid spaces, and much smaller pons. And you can also see atrophy of the cerebellum, which is responsible for cerebellar ataxia as well. So this does appear to be a neurodegenerative disorder which can cause brainstem symptoms to be aware of. So to finish my section of this talk, I'm going to mention what research studies are going on to try and find treatment for Wolfram at the moment, where it is. And this is just an overall pipeline supplied by my colleague, Professor Urano in St. Louis in America. And you can see from finding a mutant gene to mutant mRNA to mutant protein. I've already mentioned it affects the endoplasmic reticulum unfolded protein response, ER stress. I didn't mention the calcium homeostasis, abnormal mitochondrial function leading to cell death, and then the clinical manifestations. There are early studies going on at the moment looking at potential gene therapy to try and approach this from adeno-associated virus to try and treat the Wolfram gene. And the best progress is being made in the vision, really, trying to undertake gene therapy for the vision loss in these. And there's colleagues in Belgium who are doing some fantastic work looking at this. This is a long way going forward, and it's a long way from clinical studies yet. There is an industry interest in repurposed combination therapies originally used for motor neuron disease to try and treat or enhance some original residual functions of this. And there's phase 1 study going on in 12 participants in St. Louis at the moment looking at it. There's been an existing study trying to compensate for the abnormal ER homeostasis, and one that's been tried as dantrolene sodium. A phase 1, phase 2 trial was undertaken on this, didn't really show any benefit to either diabetes care or the vision loss. And then there are very good preclinical studies looking at GLP-1 receptor agonists, which I will mention. The study I'm going to talk about in a moment is the use of sodium valproate, which is really at this end treating the cell death as a clinical trial to go forward. Before I do that, I wanted to touch on GLP-1 receptor agonists because they've been in the news a lot, as we know, for treatment of originally for type 2 diabetes, and now, of course, being used for the treatment of obesity in adults and, of course, in children as well. There's been a very nice overall paper from colleagues in Belgium particularly, but also in Italy and colleagues in America, looking at the effect of GLP-1 receptor agonists in mouse models of Wolfram. The studies appear to demonstrate that they can improve diabetes in Wolfram mouse models. They can preserve beta cell survival, and in iPSC neuronal precursor models from patients, they appear to improve mitochondrial function in these models of Wolfram. So GLP-1 receptor agonists may well become a logical treatment for the management of at least the diabetes in Wolfram, and perhaps eventually in the neurodegeneration. As you know, there are ongoing studies of GLP-1 receptor agonists for Alzheimer's disease and Parkinson's disease. And I think if those studies show clinical benefit, then there'll be a very strong case to try them for the neurodegeneration in Wolfram. In the moment, excuse me a second, I'm just on a call. In the moment, I'm presenting our phase 2 efficacy study of sodium valproate to try and reduce or slow down the visual loss in Wolfram syndrome, and look at the safety and tolerability. And I'm going to spend the last 5 minutes or so talking about this trial. So this came from identifying a drug target about 10 years ago. We know in Wolfram syndrome, the cell models grow slowly and they have increased apoptosis due to downregulation of a cell cycle regulator. So we know that all cells, including neuronal cells eventually, will go through a growth phase, a stationary phase, secondary growth phase, and then mitosis. And in neuronal cells, they obviously don't go through mitosis, but they can go on through this into cell death and apoptosis. The cell cycle regulator, P21-CYP, is a checkpoint at this point, guarding cells from the G1 to the stationary phase. And in studies that we did in cell models of Wolfram, we could demonstrate that the levels of P21-CYP cell cycle regulator were reduced in these 3 columns, KD1, KD2, KD3, Wolfram models, compared to controls. When we then went on to have a look at the expression of these, we saw the expression was reduced, as I've said, but and there was increased cell death in those cells. When we looked at the cells that were held in G2 phase of the cell cycle, those cells that retained P21-CYP expression, which are these light gray ones, had much lower levels of cell death than those cells that had lost P21-CYP expression, which had much higher levels of cell death. Therefore, we hypothesized that if we could increase that cell cycle regulator, P21-CYP, we could hold cells in a stationary phase and stop them going on to apoptosis. So we undertook a targeted drug screen and looked for compounds that we could repurpose that were already licensed in children, known to increase cell cycle regulator expression, that would cross the blood-brain barrier to treat the neurodegeneration. And out of 21 drugs we tested, 5 had some effect. The best one was sodium valproate. And we chose it because it's had decades of clinical use. It's known to be a neuroprotector via several targets, including HDAC, as well as the cell cycle regulator. We had safety data in 3 participants, patients. It was off patent, and that we know the safety profile. So the hypothesis is that if we can increase P21-CYP expression, we can prevent neuronal death in depleted cells, and that we think that it will increase its expression levels through P21-CYP. And we chose vision because it's a marker for neurodegeneration in patients with Wolfram. So we went for orphan drug designation with the European Medicines Agency in 2014, which should allow us access to EMA protocol assistance and incentives for SME to join us. And we've got the indication for the treatment and progressive neurological manifestations in children and adults. And then the EMA advice, we designed a clinical trial with their support so that if the clinical trial is successful, we can go for marketing authorization with their support afterwards. And we chose vision because we asked families associations in the UK, France, Spain, and USA, what do they think was most important? And they all put the loss of vision more important than the diabetes. So we designed a clinical trial with an outcome for the vision. We chose as the outcome measure a progression of vision loss. And this is data from the research clinic in St. Louis. And on the y-axis is visual acuity. And a visual acuity of 0 is 20/20 or perfect vision. And a visual acuity of 2 is you can only count fingers. And on the x-axis is the age of different patients with Wolfram seen in the American clinic. And each colored line is an individual patient followed up over 3 or 4 years, and their vision is going from the bottom left to the top right, i.e. vision is getting worse. If you draw a regression line through that, you can predict the rate of vision loss for the average patients. And we've powered the clinical trial to see if we can halve that vision loss by at least 60%, so that a child diagnosed at the age of 10 with the treatment will still have useful vision loss well into their 20s and 30s, at the very time when they're going through higher education and school as well, to try and support their vision. So this is the trial schema. It's 2-to-1 randomization in favor of sodium valproate. It's a double-blind trial. So we've got 2/3 of patients treated with valproate and 1/3 with placebo. It's a 3-year follow-up to measure the vision loss, and there's 11 visits over that time, and we've including glucose tolerance tests to look at the effect on diabetes. It's a consortium between colleagues in the UK, Almeria in Spain, Montpellier and Paris in France, and my colleague Wojciech Mlynarski in Poland. And we've recruited 63 participants to this trial across 6 different centres. So now the final patients are visiting every 6 months for vision checks and every 12 months for an MRI and a glucose tolerance test. And we're completing diaries for treatment, mood, bladder function and safety blood tests. The last patient last visit is in October. And by that time, we'll have followed up 63 participants, which is sufficient to find out the outcome. We will then collecting the data and a data log at the end of December, and we should have an outcome, a definite answer. Does sodium valproate slow down the disease in Wolfram by about March or April 2025? If the trial is successful, we'll then apply to the EMA for marketing authorization for a new indication for sodium valproate through the healthcare regulators, and we'll do that with an SME. And obviously, as it's sodium valproate, we have to follow the pregnancy prevention program to avoid patients taking it when they're pregnant as well. So I'm coming to the end now of my section. I've mentioned 4 different conditions. The management of the diabetes in these for HNF1 alpha, as you know, will be sulfonylureas, but they may eventually need insulin. For Bardet-Biedl syndrome, it's insulin-resistant diabetes, and in the last 12 months, setmelanotide, MC4 receptor agonist, has been licensed for use for the management of obesity, and second line for diabetes is GLP-1 agonist, probably dulaglutide now rather than liraglutide. For Alström, insulin-resistant diabetes, sadly, setmelanotide is not licensed, but GLP-1 receptor agonists are, and we're moving now to semaglutide for Alström. And for Wolfram, insulin-dependent diabetes, we're treating with insulin replacement and CGMS with downloads. Many patients are on pumps. There is tentative evidence for milder patients that GLP-1 receptor agonists, and we're waiting the outcome of long-term studies. I put here the management guidelines. My colleague Pietro was fundamental in the consensus guidelines for Alström syndrome. There's Frontiers in Paediatrics publishes a guideline on managing Bardet-Biedl syndrome. There's been a recent review from Diabetes Therapeutics about treatment options for MODY, which is a really nice systematic review I'd recommend. And then we've published online in Gene Reviews, Wolfram syndrome, spectrum disorder, and the genetic and the clinical management of Wolfram in that. So I want to thank the funders for the clinical trial, the UK Medical Research Council, and then the French Wolfram Association, the I Hope Foundation, the Snow Foundation, and Wolfram Syndrome UK, without whose help we've not been able to study these conditions at all. And then a big thank you to the teams who are running the clinical trial in the clinical trials unit, the clinical research facility, the international collaborators in Europe and America, and our patient support groups that we have that side, and the clinical teams. And I think my time is up, and I should now hand over to Federica. So thank you for your attention, and I'll stop sharing.